changes in the shape of the bladder. Apart from the normal variations and inflammatory changes in the shape of the ureteral orifice and the changes in the shape of the ureteral orifice due to prostatism or neoplasm, the following changes are noteworthy. 1. Cystocyl. 2. Ureterovesical cysts. 3. Trabeculation and sacculation. Cystocyl. The importance of cystocyl is measured chiefly by the vaginal protrusion, the amount of residual urine, and the secondary cystitis. A cystoscopic measure of its extent is the angle at which the cystoscope must be tilted in order to examine the ureter orifice. For in proportion as the anterior vaginal wall gives way, the trigone drops from the long axis of the patient's body to the transverse axis, so that to approach the ureter orifice of the well-filled bladder in a case of cystocyl, the ocular end of the cystoscope must be carried well forward under the pubes. Even when this is done, the trigonal markings are so much obliterated in these cases that identification of the ureter mouth is often extremely difficult. Plate 1, Figure 1. Figure 1, cystocyl. The ureter orifice is in a depression. All trigonal landmarks lost. Ureterovesical cyst. Small dilatations of the submucous portion of the lower end of the ureter are seen as little pouches that balloon up with each wave of ureter peristalsis. If large, they are seen as more or less fully distended cysts. If enormous, they may so fill the bladder and distort its landmarks as to be very difficult of diagnosis without Koller-Gall injection. Plate 1, Figure 14. Figure 14, intravesical ureteral cyst. Trabeculation. The beginner mistakes the folds in the fundus of the normal bladder for trabeculation. Practice in cystoscopy will remedy this error. Slight trabeculations can only be recognized when the bladder is completely filled. It then appears as a crisscrossing of little short elevated ridges in the mucosa. Plate 1, Figure 3. Figure 3, orifice of a saccule in a chronically inflamed and trabeculated bladder. It is usually most marked in the fundus. Marked trabeculation is unmistakable and is often associated with sacculation. Sacculation. The orifice of a saccule is simply a hole in the bladder wall. The mucous membrane about this may or may not appear inflamed. It may be possible to turn the cystoscope so as to be able to see the bottom of the saccule. But as a rule, its size can only be measured roughly by the introduction of a graduated ureter catheter, and more accurately for the larger saccules, by Koller-Gall injection and radiography. An enormous saccule may so distend the bladder as to confuse the cystoscopic picture. In such cases, Koller-Gall injection is the only resource available.